this is a painting. It's called Isolation, and it was created by a South African artist in 2020 when the COVID-19 pandemic was hitting the headlines globally. And I wanted to start with this just to remind us all about the feelings of isolation, being cut off from our friends and family, being cut off even from strangers. But despite this, we all remained in contact with public health information via the TVs, radios, our smartphones, and the internet. But for many people, not just during COVID times, but a lot of the time, there's no access or no regular access to news updates on the TV or internet. And during the COVID pandemic, there was real growing concern that the people that rely on face-to-face visits for public health information were going to be cut off. And to add to that, there was growing concern that the resources that were going into COVID response were being diverted away from other really important public health programs concerning vector-borne diseases like malaria. So just keeping that in mind, it's my pleasure today to introduce a project that has been funded by Bayer. It's a pilot based in Mali, and it's a collaboration between Arctic Innovation, for whom I work, LSHTM, and Vyamo. So my name is Dr. Sophie Wolf. I'm Head of Strategic Partnerships for Arctic Innovation. And Arctic Innovation is essentially part of the London School of Hygiene and Tropical Medicine. So I've worked for the London School for a while. I'm actually a medical entomologist, and I've moved into partnerships. So this has been really, really educational for me to be here, and it's a pleasure. And I would like to thank Bayer particularly for funding the work and continuing to do some work together. So Mali is one of the top 25 poorest countries in the world. 19% of all deaths are due to malaria, followed by lower respiratory tract infections and diarrheal disease. And a quick introduction to Vyamo. So I think many of you have heard, from talking in the room, many of you have heard of Vyamo, but for those who haven't, they host a very simple platform where people with any kind of phone, a smartphone, but crucially a basic phone, can dial 321 for free and access a whole wealth of information. And they have the choice of what information they listen to, depending, and they select via their keypad what it is that they want to listen to. What's also really, really powerful about this platform is that you have real-time feedback about the numbers of people that are accessing it, how long they're listening for, the demographics within that. And just as an example, because I haven't got time to tell you about all the results, but it tells you, so at baseline, which was early 2020, you can see that 53% of the people responding only had water. 19% had no means of washing their hands at home at all. And 28% said that they had water and soap. And then post-message launch, which we can't attribute just to our information listening. You know, everyone was talking about soap during COVID. But more people had access to soap and water during that time. So very simple way of collecting huge amounts of really meaningful information. I think what's probably the most interesting thing about this whole presentation is the incredible impact of and reach of the pilot. So between the launch of the pilot in September 2020 and the final month of message hosting in August 2021, the information was accessed 1,768,000 times. And that's not just accessed, actually, that's listened to. So it's not that many calls, it's that many calls and listening to over 75% of the information that was available to them within this messaging. So I've got a few more facts, because I think people here will be interested. So callers listened to a total of over 8 million messages. So an average of 4.7 messages per call. Individual messages tended to last between 30 and 60 seconds. And people tended to remain on the phone call for between 2 to 4 minutes. So I think it's it's a surprising amount of time. What's also really, really interesting is the amount of people that actively responded to survey questions. So I think definitely in the UK, you wouldn't get very many people. As soon as you ask a question, you put the phone down, basically. But we had over 1 million survey responses. So we had a huge amount of data. Some listener testimonials. So one listener said, "Thanks to the messages, I better understood the importance of respecting barrier gestures, such as hand washing and coughing into my elbow, and since then I've observed them to protect myself against the coronavirus." Another one was, "Since I listened to the messages, I watch over the hygiene and cleanliness of my house, as well as the food that I prepare. Moreover, I previously used the mosquito net only during the rainy seasons, but since I listened to the messages on malaria, I use the impregnated mosquito net in all seasons." One other thing that we noticed was that 17% of the listeners were women, so the majority were from male-registered phones. What we don't know, really, is how many women were listening, and how did they listen? Did they listen in groups or did they listen individually? And so we're happy to say that we're going to be conducting some focus group studies to really understand a bit more about that data. So just the take-home messages, really. I think that the reach of the population within Mali, so we had over 800,000 people listening. In a population of 20 million, that's 4% of the whole population. The Vyamo platform is available in 36 countries, and there is so much more that we can do with it. I think particularly from our perspective, we're very interested in behaviour change and measurement, obviously. So I think the survey tool offers huge potential, even in randomised control trials. So first stop, Mali. Next stop, we've got the focus group studies, and we're also going to be working in Malawi currently. So yeah, I'd be delighted to speak to any of you about any of this, so please do get in touch. My email address is there, or speak to me during what little time we have left. I've had the pleasure of speaking to a lot of you already, so thank you.
Hi. Well, you saw me yesterday. We talked about vaccine. Today, I'd like to spend a bit of time explaining what PASS does. I think there are many questions about what PASS does exactly, and I'll specifically speak also about what PASS does together with the Bayer Foundation. So at PASS, we are a 45-year-old organization, a group of innovators actually working to eliminate health equities. That's our mandate, and we currently work across 70 countries. We've got about 1,600 staff, sorry, I'm moving that, 1,600 staff around the world, and our global team of experts ranges from experts in clinical trials, vaccine development, but also public health expert, as well as digital health expert. You saw our colleague Sky yesterday talking about our work hosting Digital Square. Most of our staff is based in the countries where we work. So although we were funded in the US in Seattle, over 60% of our staff is in the countries where we operate. Our work spans around 5 main areas. Vaccine and vaccine development, I talked about that yesterday, talked about the example of Menafrivac, but also the co-development of the first ever malaria vaccine. I won't dwell too much on that. We do also perform drug development, although it's a smaller portfolio than our vaccine portfolio. We very importantly work around diagnostics and diagnostics development, in particular point-of-care diagnostics. This is an essential element to health outcome. If you don't reach the right diagnostic, then you're not providing the right treatment, then you don't get the health outcome that you desire. I'll just take an example here regarding neglected tropical disease and onchocerciasis, also known as river blindness. Until recently, the only way we could test for river blindness was actually a skin biopsy. And I don't know if any of you have had a skin biopsy, that's pretty unpleasant. And when you go to villages and want to do skin biopsy, first year you manage to catch the kids by surprise, but the next year, they run very fast. And so what we have developed is a simple a rapid diagnostic test, like a malaria test. So you do a small prick at the top of the finger, drop of blood, and you get the results within 15 minutes. This test is unfortunately yet not widely adopted, and that speaks a lot for the need of raising awareness of neglected tropical disease and ensuring that, as Dr. Obi was saying, policies are following the science and the innovation. Then we work on delivery, and there we work side by side with ministries of health on a variety of programs from HIV, tuberculosis, malaria, neglected tropical disease, and also emergency preparedness and response, including surveillance. All that culminates in strengthening the health system. And you've heard me yesterday saying how important it is to move away from just a disease approach and build health systems that are going to be able to cater to the needs of our patients. Unless we do that, we are going to be prone to have to send new streams of funding every time a COVID pandemic arises or an Ebola pandemic arises. If you build a strong health system, it's no longer going to be the case. If you build a strong health system, this system is going to be able to adapt to an evolving situation. And most importantly, building a strong health system will enable you, or enable us and the countries to really care for the patients and patient needs. Too often we, as healthcare workers, see a disease when we have a patient in front of us. And that patient often comes with several comorbidities. And if you're just addressing the one that's visible, you're missing the plot. So those are some of the areas, I'm not going to list them all, where we work. We even work a little bit on water and sanitation, in particular around sewage surveillance. So end-to-end solution, human-centered is really a key word there. We have developed actually several human-centered design lab in Kenya, in Zambia, and in Uganda to make sure that not only do we involve the healthcare workers, but also, very importantly, we involve the communities and the individuals in the design of the solutions we are providing. This is our strategy for the period 2020 to 2025. We're in the middle of that, and the goal of our strategy is really about advancing health equity through innovation and partnership. Health equity is about providing the right health solutions to people, and it's not always going to be the same. So it's not a blanket approach. It's really understanding community by community what is needed. And you can do that by engaging and partnering with the community. You can do that through science and technology. You can do that by building more resilient health system. And you can do that by being ready to prepare for emerging health threats. I was actually in West Africa in 2014 when the Ebola crisis arise. It stopped the systems completely in Guinea, in Sierra Leone, and in many other countries. And this is a disaster, and this is something we can no longer afford. So we need to be ready. We need to be ready to respond, and we need to be ready to make sure that we have a continuity of care no matter the pandemics. So very specifically, what do we do with the Bayer Foundation? In Zambia, and that's a more recent project, we've been working for years now with the Bayer Foundation in Senegal, but in Zambia, we actually support COVID vaccine preparedness, rollout, and surveillance. And there we have two main activities. The first one is one of capacity building, where we've been training healthcare workers, training traditional leaders to ensure that they become advocates and champions of vaccine COVID. I talked again yesterday about the difficulties and the vaccine hesitancies around COVID vaccine. Actually, in the province where we work, we actually got the highest rate of vaccination across Zambia. I don't think we can claim sole attribution to ourselves. This is, again, a partnership. This is working with ministries of health and health authorities at the province level, yet this is extremely important, and this is a model that can then be replicated in the other provinces. Then we also work on surveillance, and Bayer supported us in partnership with the University of veterinary, Jesus Christ, that's a difficult one, veterinary medicine, and we've been able to upskill their lab not only to do genomic sequencing, which is extremely important to identify strains and variants, and everyone keeps talking about the next variant. Well, this is one way we can identify those lineage. Then also serology to be able to evaluate the level of population immunity, so people that have been exposed to COVID. And the last one is really important one. This is a technology we've developed initially for polio, but that we are now able to use also in the COVID context, which is wastewater surveillance. So you essentially take sewage and you look for traces of COVID in that sewage within the community. And if there's none, then you can move on to another community. If there are, then you start actually a population testing. This is extremely efficient way of getting good visibility on what's happening in terms of infectious disease transmission at community level. Then in Senegal, we have developed a model of community health worker and community champion. We are there again working on capacity building and awareness raising. Capacity building, so this model of community champions, and we talked about community health workers earlier today, this is a model that is people from the community that we train around malaria education, around malaria response, around health-seeking behavior, and they go from household to household, and they use mobile phone to identify the current understanding that people have regarding malaria transmission, and they target their message based on what the population's beliefs are at a given point of time. And by using digital phones there, we are able to go back and see over time how much progress has been made in people's understanding and people's behavior. This is work we are doing in the Tambacounda area, which is the south part of Senegal. This is the crossroad between Mali, Guinea, and Senegal. This is a difficult remote area with very high malaria transmission, very poor area and a difficult one to reach. And thanks to Bayer, we've been able to establish this network of community champions. And through this network, we are now in a position to bring learning to the health system. And we are at a stage where we are going to be expanding this network throughout the region and in other regions of Senegal. And I'm almost not, I'm definitely too short to see the clock. So with Bayer Foundation, we will continue, and you've heard us yesterday with Emily talking about this digital health ecosystem project, and we are going to continue that, and we will continue working on that last mile health delivery through the community engagement. One thing I didn't mention is that those community health workers that were trained for malaria were also retrained at COVID time, because we had a discussion with Stefan at that time and said, what do we do for COVID? And so we were able to retrain those community health workers so that we could have them cascade down those messaging of social distancing, hand washing, mask wearing at the peak of the COVID pandemics. And we do all that because we do believe that better health drives humanity forward. Thank you.
I guess the burning question, why is there chronic underfunding for tropical diseases in Africa. Seems to.
Can I start by kind of explaining some of the complexity around, because something like malaria is well, we haven't really talked about it over the last couple of days, have we? So this is a bit of a switch, but from my background being in medical entomology and vector control, I think that we, just to give you a summary of the complex nature of getting rid of malaria. So we've got bite prevention, stops you being bitten, stops the malaria being spread, and a tool for that is bed nets. Bed nets work really, really well to prevent malaria. There's distribution problems, supply chain issues, potentially, that's one. Also insecticide resistance, so you have insecticide impregnation in those bed nets to kill the mosquitoes. So insecticide resistance is one issue. Diagnosis and the cost of diagnosis, but also access to rapid testing is one issue. The mutation within the detection system for rapid diagnostic testing of malaria is a challenge. One thing that Arctic Innovation are working on is odor-based diagnostics. So we're designing a handheld malaria sniffer, essentially. Surveillance, and we've talked a lot about data, and I think that's crucial, is knowing where it is, and particularly in areas where you're at the eradication phase. So where you're a country that's approaching eradication, then you need to know at borders when people have malaria and when they don't. 20% of all malaria cases are asymptomatic. You don't necessarily know if you have malaria or not. And then even within the treatment, there's anti-malarial drug resistance. So there's another challenge there. So, and the only way to kind of combat something like malaria is a holistic approach to all of those people, networks, skills working together. And the WHO, in their vector control response report, one of their key pillars is to do with collaboration, and how we get people, cross-disciplinary people, working together, sharing data. The London School of Hygiene and Tropical Medicine with Arctic Innovation hosts something called the Global Vector Hub, which is an online platform people can access to find people with skills in different countries, which facilitates something like a global research campaign. And if you're doing a randomized control trial and you want several sites, then you should be able to find different people. If you want an epidemiologist in a certain space, then you should be able to find them. But also, and crucially, data sharing. It should be a data repository. I was talking to Medic about standardization of data sets, and that's a big challenge too. So, anyway, complex issue. I'm going to pass to Philippe to kind of continue.
Your thoughts?
Yeah, I think first of all, on malaria, we should actually celebrate. In 20 years, we've halved mortality. So we went from about 800,000 deaths to less than 400,000 deaths. That's still 400 too many, but we've halved that. And the other reason to celebrate is that we actually have seen like a sharp increase in funding. We're talking about funding. So in the 2000, we were, as a community, investing less than $1 billion per annum in malaria. We are at close to $5 billion. This is an achievement in itself. Having said that, it still is not enough. Global Fund is heading toward its replenishment later this year, and they estimate that for the period 2024-2027, we will need to gather $130 billion to address the top three diseases, HIV, TB, and malaria, when we talk about infectious disease. $130 billion. Global Fund is aiming to raise $18 billion that will contribute to addressing this enormous need. One thing that we, and then other foundations and bilaterals will be contributing about $25 billion. One thing that we often forget to mention is that countries in low and medium income countries are contributing about $60 billion. And will be contributing $60 billion. So we keep saying, oh yeah, we rely just on donors. Actually, countries are putting money where it's needed, and we should really applaud that. That still gives us a gap. I don't know, I'm sure we've got plenty of people that are super good in math here. That gives us a gap of about $30 billion. So guys, by any means, if you've got some spare change, I'll be organizing the collection. 30 billion that we need to find to be able to address our malaria objectives. Malaria, HIV, TB, you can argue this. This is great because those diseases are massive killers. What about the others? What about what we call neglected tropical disease? Those ones, I was talking about river blindness earlier, those ones are a real challenge for us to address because of lack of awareness, because of lack of health system being ready to manage them, and there we need to really focus on having a decentralized approach to those diseases so that we can have people that are agile administrators of health at every level of the health pyramid to address that. Then I'll pause in a second, but I think one thing that's really important compared to what I was saying earlier is that a few weeks ago I was at the World Health Assembly, and for the first time I heard loud and clear, and we all heard loud and clear, countries from Africa and Asia saying enough of just vertical funding. This is great that you're funding HIV. This is great that you're funding malaria. This is great that you're funding immunization. You need to invest more strongly in the health system. And I was telling someone yesterday that the most shocking experience I have, and I've seen that when I lived in Senegal, was actually Gavi funding supply chain and cold chain for vaccine and funding solar fridges. Great, we can have vaccines that remain fresh, and you can even store your fish or your beer in the fridge. Yet, you haven't electrified the health facility. So I've literally seen nurses having to open the fridge door to read a posology for a drug. This is insane. If we want to have healthcare workers that are motivated, that are willing to take their part of that health system resilience, we absolutely need to give them decent wages, decent living conditions. None of you will be accepting to go to a remote health facility with your children if there's no electricity where you live. And I think, this is really important. Those basic things need to be really targeted. Running water, electricity. Have you ever tried, I don't have my phone, have you ever tried to deliver a baby with a smartphone? I dare you. I mean, this is a type of situations that we are living in some of the health facilities, and that, as an international community, we cannot accept. And then we can continue doing that if we just do vertical, because vertical in reality starts creating parallel systems. I don't trust the national pharmacy, so my HIV drugs will go through a different route. And I don't trust the healthcare workers, so I'm going to hire specific healthcare workers to... We are weakening the system rather than strengthening it. Unless we strengthen the system, there is no way we are going to cope with future pandemics, and most importantly, there is no way we are going to cope with non-communicable disease. And this is the one thing that no one talks about, because no one wants to fund non-communicable disease. Too complicated. If I go to a donor and say, you know what, I don't know how many patients there are, I don't know where to find them, I don't know how to treat them, can tell you, however, that for the next 20 years, we are going to be best buddies because we are not going to solve the problem in 20 years. And then if I go to the same donor and say, you know what, I can have 30 million kids vaccinated in 3 months. Which option do you pick? But non-communicable disease is a major killer in all of our countries. It's underdiagnosed, under-treated, and this is a terrible sentence for people that are diagnosed, because you're going to have to pay for treatment for the rest of your life. So building those health systems, in my view, is no longer an option. This is a must, unless we are going to let down those millions of people that are in need. Sorry.
Yes, no.